Hi, it's Dr. Ali, a cardiologist with 3 decades of educational experience, continuing my series of lectures for residents and medical students who should take the trouble to verify the information for themselves. Today's talk is on ICD indications. ICDs can be placed for secondary prevention for survivors of cardiac arrest, VT/VF, or hemodynamically unstable VT. They can be placed for primary prevention in patients with high predicted risk of sudden cardiac death, but no prior VT/VF event. The main prerequisite, it's a class 1 prerequisite, expected meaningful survival should be more than 1 year with good functional status. If you have a survivor of VTAC, VFib arrest or unstable VT, check and see is there a completely reversible cause. For example, hypokalemia, in which case treat this cause, no ICD is indicated. If there is no reversible cause, ICD is indicated. The main clinical trial for this was the AVID trial from 1997. This clearly showed that ICDs were superior to amiodarone. Now considering patients with coronary syndromes, if someone has acute MI or revascularization on day 0 to 40 days post-MI, 0 to 90 days post-revascularization, wait and optimize GDMT. The Dynamite and Cabbage Patch trials show that early ICD does not improve survival. More than 40 days post-MI and more than 90 days post-revascularization, check LVEF. If it's less than or equal to 35%, NYHA class 2 or 3, less than 30%, NYHA class 1, then an ICD is indicated based on MADIT-1 and MADIT-2 trials. The situation with non-ischemic cardiomyopathy is more nuanced. If LVEF is less than or equal to 35%, NYHA class 2 or 3, and they have been optimized for more than 3 months with GDMT, then the SCD-HEF trial showed an overall survival benefit. However, it favors younger age individuals with low competing risks. The Danish trial in 2016 showed reduced sudden death but no overall mortality benefit. Older patients died of non-arrhythmic causes. Therefore, shared decision making is important, particularly in non-ischemic cardiomyopathy. Considering the heritable causes, hypertrophic cardiomyopathy, if there is a family history of sudden cardiac death or unexplained syncope or non-sustained VTAC, LV apical aneurysm would qualify for ICD. Long QT syndrome with recurrent syncope or VT, despite optimization of beta blockers, qualifies for ICD. Brugada syndrome, spontaneous type 1 EKG plus syncope or cardiac arrest qualifies for ICD. Cardiac sarcoidosis, EF less than or equal to 35%, or extensive late gadolinium enhancement on cardiac MRI plus syncope VT qualifies for AICD. Remember, ICDs are miraculous but not benign. It terminates VTAC VFib. Number needed to treat overall is 10 to 15 over 3 to 5 years for primary prevention. However, they do give inappropriate shocks that increase mortality, cause post-traumatic stress disorder, they lead fractures, endocarditis. Therefore, a subcutaneous ICD was developed. In the Praetorian trial, they showed that subcutaneous ICDs avoid venous lead complications, but they offer no Brady pacing or antitachycardia pacing capabilities. Finally, remember to optimize GDMT, at least 3 months of medical therapy. Respect the waiting periods. No prophylactic ICDs within 40 days post-MI or 90 days post-revascularization. Treat the patient, not the EF. Expected meaningful survival more than 1 year is an absolute must. Never place an ICD for EF alone. Thanks for watching. More to follow.